Hello, I'm Dr. Donald Jurovich from the University of North Dakota, Department of Geriatrics. Today we have a presentation on the geriatric 4M of mobility, and this will be divided into three microlecture components. The presentation is supported by a HRSA-funded Geriatric Workforce Enhancement Program, and a lot of the information can be found at the website for the Dakota Geriatrics listed here. The goals are to understand gait and postural changes with age, like to report the epidemiology of falls and injury, and appreciate the fact that it's increasing each decade with the aging population. We also want to apply the 4 M's in terms of fall risk assessments in a consistent manner. And associated with those assessments, whether they're screen positive or negative, we want to prescribe an action plan for fall prevention. And finally, we would like to establish a mobility plan for both fallers and non-fallers. So if you think about the 4M of mobility, the first part of it is to consider fall risk and its mitigation. And the second part is to consider an overall mobility plan, which is more focused on physical activity and exercise. So before we get started, I just wanted to share some geriatric quick facts here in the regional area of the Dakotas. So it turns out that North Dakota and South Dakota are pretty similar in respects to the older adult population. North Dakota is 6 for people over the age of 65 relative to the rest of the U.S. states. It's second only to Rhode Island in people over the age of 85. And both states are 3rd and 4th ranked as the highest for the percentage of Alzheimer's disease amongst the older adult population. And as we will see, Alzheimer's disease is a risk factor for falls. So it may not come as a surprise that the fall rate is high amongst older adults and is remarkably increasing over each decade. And you can see in the graph here that the death rate from falls, unintentional falls, is linearly increasing. There's data beyond 2014 that continues to show the trend of approximately 150% increase in the fall rate over the last decade. So we clearly have our work cut out for us. Also, just wanted to point out there are some health disparities that we need to be mindful of. That in this case, comparing difficulty walking, which is a risk factor for falls, is more prevalent in African American men and women. And that holds true for all the subsets of aging going from 65 to older. So I'd like to share a clinical case here that might be shed a little knowledge about how we're trying to approach this. So this is an 82-year-old lady who's brought to your clinic by her daughter, who reports that her mother gradually fell to the ground when she walked to her car while coming to the doctor's visit. Described as if her legs got heavy and went out from under her. She has multiple chronic conditions that you can see here. She has a sulfa allergy, and she's on evidence-based medications for her heart failure and diabetes, as well as primary prevention with vitamin D. So the question comes with this gradual falling as opposed to an abrupt fall. How do you assess an older adult who reports the fall in this case? And more importantly, how many of our patients do not report a fall because they think, well, that just happens so frequently, or just they didn't get injured, so no big deal. So there's that issue. And then the second issue is what kind of action plans can we prevent future falls and injury that are evidence-based medicine? So I'd like to speak about the postural changes with aging that predispose to falls. And you can see here the declination of upright posture that occurs in the older adult. And basically, you can see here, which is good posture, that in the right-hand picture, that the shoulders, hip, and malleoli of the ankles are in alignment. So that's a good plumb line. But look what happens to the plumb line on the left side here. If you had a plumb line from the ear downward, you see that the plumb line is forward of the knees, thereby showing that the shift in weight and gravity will be forward, thus predisposing individuals to a lean forward fall, either trip fall or possibly slip fall mechanism. Another interesting observation is that postural sway increases with increasing age, and so that there's anterior, posterior, as well as lateral sway increase in the older adults as measured by what we call these forced plate evaluations. And you can see the mechanism here on the left, where there's a computer-generated line that shows the postural sway, and there is evidence that if you, as an older adult, have 2 standard deviations from normative age-matched changes, that you have a high fall risk. And some programs will use these as a screening tool as well as a therapeutic intervention, trying to entrain postural sway to improve as a form of core exercise training. Well, the other problem is that not only are the mechanics changing with age, but our neurogenic responses are reduced. And so the recovery from postural perturbation is problematic, as evidenced by the sculpture here. And then the other problem is that as we get older, there's a increase in there's an increase in the change in blood pressure from supine to standing position, and that may also be accompanied with blood pressure changes within the first moments, the first few seconds, which can make a difference. And sometimes when an older adult speaks of lightheadedness upon rising from bed, that's something that we need to consider. And of course, we use orthostatic blood pressure checks as a routine measure in older adults. Just wanted to share with you this emerging concept that cognition and motor function are intertwined, and that as people become slower, as measured by their gait speed, they have increased risk for cognitive decline. And so it used to be that the old model was that slow gait speed, that was associated with falls and fractures, and cognitive impairment was a distinct entity leading to dementia. But now actually they believe that there's an interface, and that perhaps slow gait speed is representative of neurodegeneration. The other thing is that we need to consider what kind of fall occurs, and the intervention may be a little bit different for each one. So we generally characterize a fall into slip, trip, or a either lateral fall or undesignated etiology fall, or multifactorial. We also need to be mindful that medications are associated with falls. So polypharmacy, those that have 6 or more medications by in itself, increases the odds ratio for falls. And you can see the numbers here where opioids, antipsychotics, sedatives, and it doesn't matter whether it's short or long-acting, and certainly the sleepers, the Z's, if you will, are all associated with high risk for falls. Interestingly, while we treat depression fairly aggressively with SSRIs, they themselves also are a factor that can contribute to increased falls. We also need to be mindful that there are age-dependent diseases that increase falls, In the case that I reported, the most likely etiology for the gradual fall to the ground was what in old terminology would be called a drop attack from systolic heart failure. That's where people describe their legs give out from under them and they feel heavy. Diabetics have problems with neuropathy. They can't feel their feet in many cases, and that causes problems with balance and postural stability. One of the concerns with chronic lung disease is the hypoxia that occurs with exertion, and therefore creating situations where there might be gait and postural instability because of poor oxygenation of the muscles. Obesity. You think with people who are of large body habitus would be strong or perhaps have normal muscle, and they don't. And many times there's the concept of sarcopenia, which is muscle wasting, which is part of the elevated BMI in many, at least a third of older adults in the United States are obese. Polypharmacy can induce weakness. Certain medications can induce weakness as well as fatigue, so we always need to be on the lookout for those issues as adverse drug side effects. And again, it emphasizes the point of the interrelationship of the 4 M's of how pharmacy or pharmaceuticals can influence posture and gait. Frailty is a geriatric syndrome characterized by weakness, fatigue, loss of strength, and slowness. And that's an increased risk factor for falls. We also need to be aware of joint issues that contribute to falls, such as osteoarthritis. Also, bone loss can be associated with muscle loss, and that term now is called dynopenia. Again, the interrelationship between one organ with another organ that results in decline in function and performance. And then just to consider all the neurodegeneration problems such as vascular dementia, Alzheimer's dementia, Pick's, Lewy body dementia, and then Parkinson's. There's basically central nervous system problems that lead to system atrophy in terms of nerve damage and muscle atrophy that predisposes, and coordination, I should add, that adds to the increased risk for falls. So we know that dementia in itself is an incredible increased risk for falls. So to summarize this first part of our mobility considerations is that we know that falls are increasing with age, and they're also increasing with medical complexity. Falls result in injury and death, and that's actually a metric by which we can measure healthcare systems in terms of reducing falls, in terms of number of ER visits for falls with injury. We know that falls are avoidable, and in addressing the age-related changes, we need to consider what happens with posture, the stability, gait stability, also the loss of compensation to gait perturbations or balance. And then also we need to consider the issue of strength, given that there's 1% lean muscle mass loss annually in the older adult population. And then some of the issues that are associated with problems with neurosensory feedback, such as vision and hearing. Hearing also is a component that can influence aging balance. And then finally, we want to consider the systemic evaluation of the fall risk, and then provide consistent reinforcement of a fall prevention plan to mitigate the risk of future injury and death. So thank you for your attention, and I look forward to discussing with you the next 2 parts of this mobility series.